When you were trained as an EMT or paramedic, you were likely taught Gravida and Para to evaluate a woman's pregnancy and birth history. While those two numbers are useful, they do not provide the full clinical picture. In pre-hospital obstetric care, details matter. A patient's obstetric history can affect your assessment, transport decision, level of concern, and communication with the receiving hospital. That is why we use GTPAL. It provides a more complete and clinically useful breakdown of a patient's pregnancy history and helps EMS providers identify patterns and complications that may affect the current pregnancy. G stands for Gravida. Gravida refers to the total number of pregnancies a woman has had, including the current pregnancy. Every confirmed pregnancy counts regardless of the outcome. This includes live births, miscarriages, ectopic pregnancies, stillbirths, and the current pregnancy if she is pregnant now. Gravida tells you how many times the body has experienced pregnancy and provides important context during your assessment. T stands for term. This is the number of pregnancies delivered after 37 weeks gestation. These pregnancies are considered full term. A history of full-term deliveries can provide insight into how previous pregnancies progressed and whether the patient has a history of carrying pregnancies to maturity without major complications. Term deliveries are counted by pregnancies, not by the number of babies delivered. If a patient delivered twins at term, that still counts as one-term pregnancy. P stands for preterm. This refers to births that occurred between 20 weeks and 36 weeks and 6 days gestation. This is extremely important information in the pre-hospital setting because a history of preterm birth increases the risk of another preterm delivery in the future. If your patient is currently 32 weeks pregnant and contracting, knowing she previously delivered preterm should immediately increase your concern. It may change your transport priority, influence your destination decision, and prepare the hospital for a higher-risk obstetric patient. A preterm history may also explain why a patient is already under specialist obstetric care or taking medication intended to reduce the risk of early labor. A stands for abortion. In medicine, abortion refers to any pregnancy loss before 20 weeks gestation. This includes spontaneous abortions, which are miscarriages, as well as elective or surgical abortions. Regardless of personal opinions or politics, this is the correct medical terminology, and it is important to use accurate language when documenting and communicating with other healthcare providers. Pregnancy losses can provide important information about reproductive health and possible complications during future pregnancies. L stands for living children. This refers to the number of children currently alive. This number may not always match the total number of births because some pregnancies may have ended in miscarriage, stillbirth, or neonatal death. Accurate documentation gives the receiving team a clearer understanding of the patient's obstetric and family history. When you put these numbers together, they should logically add up. For example, a woman who has had 5 pregnancies, 2 term deliveries, 2 preterm deliveries, 1 spontaneous abortion, and 4 living children would be documented as G5, T2, P2, A1, L4. Always check the math. Term plus preterm plus abortions should equal the Gravida count. If the numbers do not make sense, ask follow-up questions respectfully and clearly. You may uncover a pregnancy loss, termination, stillbirth, or another pregnancy the patient did not initially mention. Many patients may feel uncomfortable discussing past pregnancies, especially in stressful situations, so maintain professionalism and avoid judgmental language. Document GTPAL on every obstetric patient encounter. It only takes a few seconds, but it provides far more information than simply writing G3P2. A complete GTPAL history helps you identify high-risk patients, improves communication during handoff, and allows the receiving hospital to better prepare for the patient's arrival. In obstetric emergencies, details save time, and time saves lives. For EMS professionals, gathering this information should become part of every routine obstetric assessment. while obtaining vital signs and evaluating contractions, bleeding, rupture of membranes, or fetal movement. You should also gather a focused obstetric history using the GTPAL system. This helps create a more complete picture of the patient before arrival at the hospital. A patient with multiple prior pregnancies, repeated preterm births, or a history of miscarriage may require a higher level of concern even if her current symptoms initially appear mild. Communication is another reason GTPAL matters so much in pre-hospital medicine. When EMS calls the receiving facility and reports a patient as G6T2, P3, A1, L5 at 33 weeks with contractions every 3 minutes, the hospital immediately understands the patient's obstetric background and risk level. Accurate terminology improves continuity of care and reduces misunderstandings during handoff. GTPAL is simple to learn, quick to document, and valuable during every obstetric emergency. The more consistently you use it in the field, the easier it becomes to recognize high-risk pregnancies, communicate clearly with hospital staff, and provide safer patient care.